Excellent. Right. Thank you very much. Well, welcome along. Sorry it's a little bit delayed in this session. Hopefully in the right place. Oh, no point doing that. It's already moved on. Personalisation in action. So we're keen today to hear from a number of speakers about how they are delivering services from a personalised point of view, how they are delivering outcomes, some of their challenges they've faced, how they've succeeded, and indeed some of the questions they may pose to you about challenges for you to take forward. Just to take you back to the morning session of the plenary when Alison talked about enablers, you'll handily see a few hexagons up there. And for me, in everything you hear today, it's understanding how you can deliver some of those enablers to deliver that personalisation in action, whether that be a benefits realisation model, whether it's looking at your workforce and strengthening their awareness of enabling solutions and most importantly wraparound services, whether it's looking about the infrastructure you have in place and most importantly the partnerships of who you work with. So hopefully, with a nod from my speakers, they will be hopefully covering some of the points I've just said. But if I can start off introducing Paul Burney to the stage, Chief Marketing Officer of Anthropos Digital Care.
Thank you, Nathan. Given that I'm going to start by thanking you for the opportunity to speak, but also to congratulate the TSA, Alison and Nathan and the team on putting together an event. It is fantastic to be finally back in front of people and talking to them. Given that these guys have only given me a few minutes, I am not going to waste them with the sales pitch for Anthropos, which you'll be glad to hear, nor am I going to give you an in-depth review of the technology that we use. But I am going to argue with you that if you really are interested in unlocking personalised care outcomes, then you're going to need to embrace connected care. The Social Care Institute for Excellence defines personalised care outcomes as having the following three characteristics. It's all about improving health and well-being, it's about improving the experience, and it's about improving services. There's no mention of technology in there. What is at the heart of that, though, is people. I would argue with you that in order to be able to deliver a better personalised care outcome, you need to understand the person better. That is the critical element here that we need to be helping you with. We need to understand the person better, not just what they tell you, not just what you might observe through carers and family being in there, but what happens when you're not there. What is happening in the other 23 hours of the day when nobody is there and that person is on their own? And this is where connected care fits. The goal of connected care and the way it works is to put small devices and sensors into the homes of those people, use those devices and sensors to collect data, and that data gives you an understanding of what is happening across key elements of that person's life. And in particular, what we focus on is this. We want to understand the environment in which they live. We want to understand their behaviour and their daily routine. We want to understand both their physical and their mental well-being. And we want to understand their safety and security. And that's essentially what connected care platforms do. They collect all the data that gives you a view on those four things. The other part of how connected care works, though, is to take that data and to do something with it, to turn it from data into intelligence. Because actually, as carers, what you really want to know is, if I've understood the needs of those people, can I understand if something changes in those care needs? What are the unmet and the unseen care needs and the changes in those people's lives? So actually what connected care can do brilliantly is help you spot, understand, and then act upon changes in that person's life. And at Anthropos, we focus not on the technology, but on answering three key questions for you. We want to know, is that older person all right? We want to know, has something changed in their life that means they need help immediately? And I think most interestingly of all, we focus on, is something changing in their life that means that you should consider it and look at it? And we look at those as actionable insights, things that are changing over time that would be hard to spot unless you're observing someone. So if you think about combining all of those things together, the ability to understand unmet and unseen needs, to understand someone's environment, their well-being, their safety and security, and their health and well-being, then all of those things added together should give you the ability to make better informed care decisions. Ultimately, that is the goal of what connected care platforms are about, helping you make a better informed care decision. If we can do that on behalf of care commissioners, on behalf of local authorities and domiciliary care providers and others, what can we deliver? We can deliver better care outcomes for the older person themselves. We can deliver a better care experience, and we can deliver better use of time and resources. If there's one thing that the COVID crisis has shown to us, is that the ability to be able to check on the health and well-being of people who were isolated and on their own, couldn't have family visiting them, were limited as to the amount of care time that could get to them, having the ability to know what is happening in those people's lives was absolutely crucial. Knowing which of those people needed help at the right time and what particular help they needed was something that Alison emphasised right at the start of her presentation today. So that is the goal of what connected care is about. It also happens to deliver two other things. It delivers peace of mind and reassurance for family members, and most crucially of all, if we really want to use it to unlock personalised care outcomes, then the goal and the power of connected care is to support older people to stay safe and well in their own homes for longer. There you go. I told you I wasn't going to take much of your time. I was only going to use a few minutes. No sales, hardly any mention of the technology. If you do want to talk to me about the tech, we are on stand 25 somewhere at the back over there, but I'm going to hand back to Nathan. Thank you for your time.
It's grand. Thank you very much, Paul. Hopefully that sets a good challenge for people to think about services as well as the enabling technology to think about the data and insights. What we'll do next is I'm going to flick this on. We're going to hear from Dr. Margaret Wierskie from Scottish Government, Director of Technology Enabled Care.
Good afternoon, and I'm delighted to be presenting at the TSA Technology Enabled Care Conference 2022. My name is Margaret Wierskie. I work within Digital Health and Care in Scottish Government and head up the Technology Enabled Care programme for Scotland, which is focused on cross-sector services supporting scale-up and adoption. Just very briefly, I'm going to refer to the Digital Health and Care Strategy in Scotland that was published in October. I know Caroline Lamb was speaking to you earlier this morning, so she'll have gone into a little bit more detail about this. But I just really wanted to draw your attention in particular to the first aim there, which is focusing on citizens having access to and greater control over their own health and care data, as well as access to the digital information, tools and services they need to help maintain and improve their health and well-being. And we know that the last 2 years have brought this into real focus about the importance of facilitating citizens' access to digital services and support. So I'm going to focus really on some examples of digital health and care in action, particularly I think focusing on how we can facilitate and enable some of that scale up and adoption. So firstly, I'll refer to Near Me, which is our video consulting service. So Near Me was in existence before COVID, but in March 2020, we had about 300 consultations a week, and that went up to a peak of about 20,000 a week in February of last year. We have seen some levelling off, which I think is similar to what's happening elsewhere in the UK and in other countries. We have still reasonably good engagement with Near Me in secondary care, a bit more of a fall off in primary care. But what's interesting is that we're extending the platform and its the approach and all the guidance with it to the wider public sector. So you can see in that smaller graph underneath that we've seen a big rapid increase in take-up within the wider public sector, particularly within areas such as social security and citizens' advice. We're continuing to focus on health and care. We're also focusing on social care and social work. And we continue to have a real priority and focus on supporting recovery, but also that redesign of services going forward. The next example is Connect Me. So this was previously known as Remote Health Pathways, and it really just rebranded at the beginning of this year. So we're picking up on the Near Me branding and looking at something that might have a little bit more accessibility for the public. what I'm going to describe here is some work that we took forward on a pathway for remote monitoring for COVID. So this went live in January 2021 and was adopted by 7 out of our 14 health boards in Scotland. But in January of this year, we were asked to accelerate a national self-managed pathway, which is really trying to support the anticipated significant increase in COVID cases. And while this hasn't come to pass in terms of the requirement for many people to use this, I think the important thing is that we're embedding this type of pathway within our health and care systems to be able to provide resilience in terms of any future waves or variants of COVID, but also the wider opportunities around remote monitoring. And we are working on a number of other pathways, including COPD, asthma, preoperative care, and heart failure. So again, looking to see how we can embed and support adoption of this. An example of a very successful program has been our Scale Up BP or hypertension program, which we saw established in 2019. And over the past 2 years, we've seen a rapid increase in recruitment of patients across Scotland, with just under 60% of our GP practices now using remote monitoring of blood pressure routinely for diagnosis and management. So we can scale up. That's the good news. We've good evidence for this pathway. We've got really good patient engagement. It saves time, but it also importantly improves outcomes for people. So again, I think we're wanting to use this as a bit of a platform to get engagement around further opportunities. In Scotland, we're very clear that digital is across our health and social care services. So we have quite a big programme on digital social care. This slide sets out some of the work that's underway. So we have a focus on digital foundations and access, a focus on digital services, a focus on data-driven innovations, and digital skills and leadership. And you can see under those areas, there's a number of key sort of areas of focus and work. Early in the pandemic, we developed a digital action plan for care homes, given the real challenge for care homes and residents in care homes in terms of that first period of COVID. We focused on a digital inclusion programme. We focused on trying to connect care homes in with the NHS secure email. And we also looked at a number of other areas of support, including skills and training. But we have a number of really interesting projects underway. We've got Tests of Change, which is covering lots of different examples across Scotland. And again, as these Tests of Change report, we look to see on the learning and how we can promote scale up and adoption. So just on the digital inclusion in care homes, we reached about 91% of all care home residents, which was about 75% of all Scottish care homes. The majority of children's care homes did not take up the programme because they had actually were in receipt of digital devices and support through education. So we've covered a lot of the care homes and residents. And this was really focused on residents' access. So for their own well-being, for connecting in with families, for being able to do sort of activities online. So lots and lots of opportunities. And we have an evaluation underway at the moment that we'll report in the summer. And I think that'll be really interesting, really, to tease out what have been some of the benefits or some of the challenges. The programme is not just about providing devices to care homes. It's also been about providing support, training, and also where care homes didn't have adequate internet connectivity throughout the home, looking at sort of MiFi data packages. So again, a really important programme that we think will hopefully have benefits for many years going forward. The next area I'm going to sort of say a little bit about is Telecare. I know this is an area that's of a lot of interest to TSA conference participants, and again, as is the case elsewhere in the UK, we have a major programme of work underway on the transition to digital telecare, led by our local government digital office. So again, a really key programme of work. We have the imperative of ensuring that everybody safely transitions over to digital by 2025, and that's not without its challenges, not least the recent problem we have in getting some of the devices and digital devices. And I think that's something we're going to have to keep a very close eye on. Also to ensure that telecom providers aren't moving over to digital platforms before there's been adequate preparation done to ensure that anybody in receipt of a Telecare device isn't disadvantaged in any way. We have a program on data and looking at benchmarking and really important aspects of how data can support our Telecare delivery. We have a program on consistent experiences, so really trying to look at that qualitative experience of people in receipt of Telecare. And the final one is about reimagining Telecare, taking a Scottish approach to service design approach, which is really trying to, in addition to the imperative about the analog to digital transition, it's what opportunities does that bring us around digital telecare, integration with telehealth and with consumers' own devices. So again, a really interesting program, and I'm sure we'd be keen to share that with others going forward, and there may be some learning we can gain as well. Proactive wellbeing calls. This was a program of work that really kicked off in response to COVID, and you're going to be hearing from Lynn Douglas shortly from Beeld Housing, and I'm sure Lynn will cover some of the work that Beeld Housing have been doing on proactive and wellbeing calls. So we started with a proof of concept, we've moved into evaluation, and we've now got a phase 2 underway. And again, the important thing about the proactive calls is, rather than Telecare being very much a reactive service, it's about using some of the capacity and experience of call handlers to do proactive wellbeing calls based on some work in other parts of Europe, in particular the Basque country, that we've been learning from. So again, very happy to share some of the outputs of that as we go forward. Housing is another key partner with us in terms of our health and care context in Scotland. We've had a tech housing programme running for the last few years, and again we're looking at introducing the tech charter, ensuring that we're accessing the wider housing sector, not just housing associations but also RSLs and local authorities. So again, some interesting work and learning, and the digital telecare programme also has a housing aspect to that the local government digital office in Scotland are leading on. So we wanted to ensure that we weren't just focusing on the local authority side, we were also focusing on the housing providers. And some really innovative work coming out of the housing sector that I think we will all benefit from. Finally, I want to just talk about a sort of flagship programme going forward, which we're referring to as our digital front door. So this was a commitment in our programme for government, and is seen as a really key overarching programme to enable our citizens to be able to access more services, access their information, reduce admin workload, and try and get equity across the piece. Importantly, we're working on digital identity to support that. We have a roadmap set out. We will be doing consultation with our citizens and stakeholders, and looking at an early release in 2023. So this is a really, really important programme across health and care. And just as an example, it's incorporating the commitment around My NHS app, but going broader. So you can see it's about managing health and care data, accessing information, accessing services, and communicating with services. So we'll be learning from the work elsewhere in the UK. We've also got a twinning partnership with Andalusia in Spain and a knowledge exchange programme underway. We've done a bit of an international scoping of what work's already underway in other parts of Europe and further afield, to really try and inform the approach we're taking in Scotland. And I think with that, that's probably come to the end of my quick canter through some of the work around supporting digital access, digital services, and that sort of holy grail of scale up and adoption. I hope you have a great conference, and look forward to connecting in soon again. Thank you very much.
Grand. Well, thank you very much for Margaret for that. We'll move on very swiftly to another video. This time we've got Professor Jonathan Wallace, Professor of Innovation at Ulster University, who by the process of magic should come along as soon as I click this button.
Good afternoon. colleagues. I'm Jonathan Wallace, Professor of Innovation, the Faculty of Computing Engineering in the Built Environment at Ulster University. Apologies that I can't be there personally today due to existing commitments that have me kept in Belfast over the next few days when the conference is running. I'm pleased that Alison and Alan have been able to let me actually give a remote presentation pre-recorded. Last year at a panel session, we did quite a lot around AI and mental health chatbots. But this year, I'm going to focus on innovation in digital health and wellbeing at Ulster University around some exemplar projects and also some infrastructure that we have available within Northern Ireland, particularly the likes of our Chill Living Lab, our Centre for Digital Health Technologies, which is part of the new Belfast City Deal, and the new proposed design Smarter for Digital Twins. Just to recognise some key collaborators, my colleagues, Professor Michaela Black, Professor Adrian Moore, Dr. Debbie Rankin, Professor Helen McNulty, Dr. Catherine Hughes, and Paul Carlin, who are all very much involved with me in terms of these projects. The first project I want to mention is very much around data visualization and so creating a new tool set for predicting malaria risk rates and trends and intervention planning as on a pilot project in the Chroma district of southern Zambia. So it's with the National Malaria Elimination Centre at NMEC and the Zambian Health Ministry. So we have developed some spatial temporal models at Ulster to identify high burden, low burden malaria incidence and mortality. And we're currently developing an interactive visualization toolkit to incorporate these spatial temporal models along with new machine learning capabilities and an up-to-date national malaria data set. And all of this is aiming to assist policymakers and health professionals in the development of control and elimination strategies by enabling malaria monitoring, planning and early intervention. The next two studies relate to a longitudinal data set called TUDA, which is between Trinity College Dublin and Ulster and the Department of Agriculture. And so it covers a lot of information around genetic details, for example, nutrition, diet and health, and other conditions. This project was funded under the Dementia Analytics Research User Group, and the focus of this was to identify predictors of cognitive decline in older people by applying supervised machine learning techniques to data from this TUDA data set. It identified potential preliminary non-invasive evaluation methods to determine whether a patient requires a full cognitive evaluation, thereby saving health providers time and money and avoid unnecessary stress to low-risk patients. We're doing some further work in the area on this, basing on investigating aging inequalities across native and minority ethnic populations with a focus on cognitive dysfunction and diabetes, using again machine learning techniques. Building on our success of the TUDA dataset, we're again collaborating with TUDA and Trinity College Dublin on one of the very few successfully funded projects out of over 750 applications for the North-South HEA funding in Ireland. We were successful under Strand 1. And this is using artificial intelligence approaches to address mental health inequalities in Ireland through improved diet and lifestyle. So the proposed study will explore the influence of nutrition, lifestyle, genetic and socioeconomic factors on mental health problems in older people. It will also really be using this TUDA dataset, as I mentioned before, to investigate risk factors contributing to depression and anxiety and the dietary and lifestyle changes that should be implemented to help improve mental health in older people. The risk factors identified will inform dietary and lifestyle interventions to promote health and wellness in our ageing population in Ireland, both north and south. Last one in terms of projects is from our MIDAS Horizon 2020 project, which successfully finished last year. And this is really about advancing the state of the art of data identification of personalised data for use in healthcare projects. So it's really about synthetic data in healthcare. So synthetic data is stimulated from real data using underlying statistical properties of the real data. It overcomes the sensitive healthcare data access limitations by providing a more secure data sharing method than the traditional anonymization techniques that you may be familiar with. We've had great success in terms of using generative adversarial neural networks, or GANs, that preserve data utility and usefulness without compromising the privacy. So this will help support and expedite the development of innovative AI solutions that benefit researchers, patients, health service providers and health policy makers whilst maintaining a high level of data privacy. And again, there's a link to the paper in that if you're interested. One of the key things around engagement of any health and care wellbeing solution is about PPI and stakeholder engagement. And how do you make that effective? Well, we had great success in Ulster developing this tool called Engage out of a European project, and now being used both locally, nationally and internationally in terms of gaining strategic consensus. So there's been over 50 strategic workshops, particularly in the field of health and social care, over the last 5 years. During lockdown, it's been fully enhanced to enable now a full cloud-based solution, so permitting both face-to-face and virtual remote engagements. And by compressing weeks or months of data collection and analysis into a single event, Engage is really the only solution that delivers same-day objective consultation at scale, where you build a strategic consensus, and the report actually from the workshop is due almost immediately after the workshop itself completes. So it's very immediate. Second half I want to look at is about these digital health and wellbeing research, development and commercialization infrastructures. So key collaborators around this are Professor Jim McLaughlin and Professor Chris Nugent, who are particularly leading on the Centre for Digital Health Technologies as part of the City Deal. Dr. Ian Cleland and Chris and myself, who are very much heavily involved in our Living Lab. Chill and Rob Smith, who's the Director of AI and Data Science at Digital Catapult UK, who's looking after the Design Smarter Digital Twins Research Centre. So Chill Connected Health Living Lab is a living lab that promotes user-centered open innovation and very much geared around sort of PPI partnerships and iterative experimental design processes and combining with our research and innovation. That gives you access to state-of-the-art technology to assess usability and interaction with innovative technologies. So it's a dedicated environment to record user behaviours, to enhance existing and develop new digital health and wellbeing solutions. And just some of the kits available is eye tracking, for example, VR and AR kits, robotic telepresence, full audio and video recording, and then physiological monitoring, including galvanic skin response, EEG, ECG, and others. Centre for Digital Healthcare Technologies is a key aspect of the Belfast Region City Deal. We have significant industry collaboration, so Microsoft, Randox, Stryker, Kainos, BT, Deloitte, IntelliSense, NVIDIA, for example, PwC, to name a few that you can see here. Effectively, it'll develop 4,000 square metres of R&D facilities, about 45 million investment in total, world-class expertise and equipment, and large investment in the living labs at the RVH site at Belfast Trust and also a medtech park. The core pillars around it are going to be focusing on digital healthcare skills development, healthcare technology R&D, and also said commercialization aspects of health technology innovation. And core CDHT themes will be living labs, this accelerated prototyping, digital open approach approach, AI, apps, devices, IoT and systems, and then digital healthcare applied to smart cities and test beds, diagnostics, ambient assisted living, health and wellbeing, aging, cardiology, respiratory, optometry, and mental health, to name but a few. So lastly, then I just want to look at this new digital smarter digital twin centre, Design Smarter Digital Twin Centre. It'll be the first UK's first dedicated digital twinning and cyber physical infrastructure centre to support industry adoption of digital twins and complex cyber physical systems. So based in the Belfast Innovation District, the facility known as the Design Smarter Digital Twin Centre will become part of a national capability in both digital twins and cyber physical systems or infrastructure for the UK. So the whole focus is to lower the time, cost and risk associated with POV, proof of value or proof of concept development for industries seeking to adopt digital twin technologies, and to lower the time, cost and risk of innovators seeking to demonstrate new twin digital twin technologies, and to lower the time, cost and risk of transition from proof of value, proof of concept and demo to real world deployment. So again, whilst it may be initially focusing on advanced manufacturing, healthcare is a large focus of this digital twin centre. If you are interested in actually becoming a partner or collaborating in this opportunity, particularly for the Digital Twin Catapult, then I can actually please ask you to contact Robert Smith at digitalcatapult.org.uk. So it was a very quick run through. It is under my 10 minutes, I can see by the timer in this. So again, thank you for your attention. Apologies again that I couldn't be there. But if you are interested in finding out about either the research projects in more detail, I can share the papers that we've done on that, for example, or how to engage with us and the facilities showcased in this presentation going forward, then please do contact me on jg.wallace@ulster.ac.uk. Thank you very much.
Right then, I hope you noted all of that down. There's quite a lot of content there. So let's talk more about service delivery side. Can I welcome Kevin McSorley up to the stage, Head of Radius Connect 24.
Thanks very much, Nathan. Good afternoon, everybody. I'm delighted to have the opportunity to be here in person to join the conversation and share my voice with you as a long-standing traditional telecare service provider, and to perhaps try to unlock the apparent complexity of all that we're hearing today. I've been around a long time. I remember 1993 when I joined Radius to set up and develop its telecare and telehealth service, so my job really hasn't changed. It's trying to champion and realise the potential of tech to deliver remodel services with people at the centre of it. It's the role I bring to Radius Connect 24. It's the role I bring to the TSA, which I've also had the privilege to serve. And yet, as I sit today and listen, I still believe that the potential grows and the realisation of that potential takes longer and longer. But perhaps, ever optimistic, now is a moment of reinvention, forged out of necessity. So, the simple title for my thoughts today is 21 Social. Nothing to do with tech, really. It's the title of our programme for inventing, reinventing service models which are enabled rather than driven by new tech and inspired by a vision of an outcome which is socially driven, and where the lens of Connect24 as a service provider changes from solely reactive services dealing with acute incidents to a relentless focus on engagement and inclusion. It also happens to be the name of a bar or restaurant in Belfast where the mood and our vibe is determinedly social. So we are a traditional innovator. A decades-long interest in the application of tech. Focus has remained constant. It's about independent living. It's about staying safe and well, perhaps not just at home, but wherever you may be. And appropriate technology can achieve improved service outcomes. But to achieve that, we have to build really trusted relationships. Remember the clients, remember their care network, then talk about the health and social care professionals, and then talk to like-minded technology providers who share your vision. For many years now, we have been a leading incident management service, operating to the highest standards of what may be truly called crisis intervention when people need us. And the language we have used has fairly described and contributed to the limited perceptions and perhaps value of tech beyond this industry. It's an old slide and an old model of service delivery, but it remains at the heart and foundation of all Connect24 service models. And there's always an ongoing conversation about identifying and overcoming barriers to innovation. And for Radius, it is always about first protecting the safety of our clients. This is our innovation foundation. Again, a simple service model and a simple concept, delivering perhaps immeasurable or not perhaps well-measured benefits in terms of reassurance, peace of mind to clients, informal carers, maintaining independence, dignity, and their secondary additional benefits to the health and social care system and to the housing sector of enabling people to live at home longer, reducing the need for the upheaval and unsettling move to residential or nursing care, or indeed admission to hospital. So perhaps innovation requires a change of lens by commissioners. We still see the point of referral for this core service from the sector often following an acute incident, following a hospital admission, following the actual diagnosis of early onset dementia, and funding only available if you need the provision of sensors which automatically alert to an incident. If you're able to press a button to call for help, well, you don't really need our service. You don't qualify for low-level support. Pay for it yourself. This lens sees Telecare as primarily a reactive service model, missing its real potential as a preventative service through provision of 24/7 support. And it really shouldn't be about the technology anymore, but it is. The true test should be, it just works. We need wearables, we need roaming, we need discrete emergency buttons, we need non-intrusive monitoring at home, such as described by Paul, we need meaningful apps, we need flexible service platforms, and we need trusted and reliable two-way communication. Where the true potential lies is the intelligent application of that tech to empower people to live as full and independent a life as possible, to deliver a 21 social care vibe, a feeling of being protected, the safety guarantee which underpins it, enabling access to community support, but trying to improve people's quality of life. One of the most striking findings from the evaluation of what I call the brave telehealth pilot in Northern Ireland was that patients with chronic conditions valued most the call from our triage nurse team to discuss their conditions, often because the tech had indicated there might be an issue and a follow-up call was then triggered. But the real value in the preventative intervention was in a simple phone call, which had social as well as clinical value. So again, the key point is that innovation is not necessarily in the tech, it's in the relentless focus on service models which are person-centred and outcome-focused, and perhaps changing the lens. Today, we aspire to be rebels to the cause of enriching people's lives. And I must name check or give a shout out to those tech disruptors in the field, and there's traditional players who are called disruptors perhaps for the first time, who we have had the pleasure of working with and engaging with at various levels to try to reimagine models enabled by tech which are embraced by clients and carers. I'm not going to do their sales pitch for them, but if you wish to discover what they do or don't do, talk to them and also talk to us, and we'll tell you about how we try to apply their applications. Again, we're working to change the lens and perspective on the development of proactive calling, including its role in response and prevention, and encouraging the risk-averse to embrace new technology and new ways of working to enable effective and efficient delivery at scale. I don't deliver any presentation without highlighting the need for independent verification that quality matters. In the digital world of data flows, security must have increased focus. We at Radius are accredited to the ISO 27001 standard. In our perspective, this is essential in the digital world. But equally important is accreditation to the Tech Quality Standards Framework, which keeps us focused on the outcomes and a person-centred approach. Finally, how do we know that we've achieved success? How do we know what we're doing or have done has achieved our outcomes better than expected? At 21 Social Vibe, we have to talk to our tenants, our clients, our carers. And in a world where what gets measured gets done, let's please find a way of counting the smiles. Thank you very much.
Excellent, thank you very much. And to our final speaker, Dr. Lynn Douglas, Chief Executive of Build Housing and Care. Thank you.
Thank you very much. It's really delightful to be here in front of a real audience. It's the first conference I've spoken at for a considerable amount of time. The one thing I have learned over lockdown is that I can no longer run in high heels. So I've actually gone for speed rather than for fashion today, as I have been on the go since 6:30, trains, planes and automobiles, and I literally arrived 10 minutes ago. So I'm Lynn Douglas. I am Chief Exec of Build Housing and Care, and I became the Chief Exec in November 2019. For 20 plus years before that, I was a Director of Allied Health in a really large NHS health board in Scotland. And I spent most of my working life contributing to policy, implementing policy, redesigning services and trying to enable and empower people to live independently in their own homes. So when I applied for the Build job, it really was something that was looking at the same problems but through a different lens. So who are we? Well, Build Housing and Care is a national housing association in Scotland. We operate in 23 out of the 31 local authorities, and we have a range of housing offers for older people specifically across Scotland. So we offer amenity housing, and we also offer retirement housing plus, retirement housing with meals and with care. And we also have BR24, our Build Response Service, which is an alarm receiving centre. And actually, like most people that I've talked today, we are very traditional at the moment in terms of how we perform those activities. We have over 50,000 connections in Scotland in 24 hours, and we provide a significant service not only to our own tenants but also to many of the local authorities and other housing associations in Scotland. So our current customers, we know a little bit about them. Obviously, our average age on coming into our properties is around the age of 70, and we know that they don't generally start to need care until they're about 79. And obviously with the demographic and with the regions in Scotland, we have very different clients and tenants depending on where they live, with more people in the west requiring care and support earlier, whereas people in the east and further north tend to be a little bit later due to their own physical ageing. So we've looked at what is the future need, and we started to think, really for me to bring these things together strategically, we really started to think about what is our future need, where do we want to be, and what are the services that people require. You will have heard this morning from Caroline Lamb, you heard from Margaret just as I was coming in. We have a very ambitious policy agenda in Scotland trying to maintain older people living independently in their own homes. And we know that our older people want to stay in their own homes. We want them to age in place, and place is a very important policy directive in Scotland. So we're doing everything that we possibly can to help them maintain their health and fitness and actually stay in their own homes for longer. For many years before I came into housing, I was doing presentations about the contribution and the role of housing in keeping people healthy in terms of the public health agenda. And actually, I now that I'm in the housing sector, it is absolutely no different. Obviously, with the publication of the TAPI report in October 2021, there is a significant number of guidance and key attributes that are required to help the Housing Association take this agenda forward and to improve the outcomes for the people that they have in their tenancy. So to sustain their tenancy using technology and the digitalisation of how we perform that is a really important aspect of what we're trying to do. So I want to just share with you a little example of something that we got the opportunity to do in 2020. Like many people, we found during COVID that many of the statutory services were no longer able to come and deliver care within our accommodations. And we were asking our own staff, we were connecting with third sector organisations and communities, and we relied hugely on our volunteers, really to help our older people who were no longer able to receive the care that they had been receiving, and their relatives were also often shielding. So we found that food was something that people really needed. We found loneliness and isolation was a key factor, and just simple tasks like medication and walking their dog were things that we got very much involved in a much more local way than we had before. We had the opportunity to take part in a test of change with the Scottish Government, with Tech Scotland, and we undertook the Inspire project. And our thinking behind this was to try and use some of our own tenants in one of the cohorts. And these tenants that we chose, and we invited them to take part in this test of change, we knew that they were fairly independent living and that they were very low users of tech. And we thought that these individuals would really be quite different in terms of a cohort to some of the other categories that we invited to take part in this test of change. So we had 3 cohorts. Midlothian Health and Social Care Partnership, we partnered with them and we used our own tenants. They participated in this proactive telecare pilot. We use Inverclyde Council, was another local authority that we provide alarm receiving centre services for. And finally, a small housing association who asked to come on board because they thought it would be particularly helpful for those individuals. So the life curve is something that many of you may be aware of. It's a validated tool that was developed by Professor Pete Gore in the Institute of Ageing at Newcastle University. And I've certainly been involved in quite a lot of work in my previous life in terms of how we can help to keep people on the outside blue curve rather than following the pink curve that you see on the slide. And we do that through enabling and empowering and working with people to improve their fitness, preventative intervention. And it is possible to reverse some of these things that you see. So down the left-hand side, these are the order in which you lose your functions. So the first thing that you're not able to do is actually cut your toenails. And the last thing that you're not able to do for yourself functionally is eat and drink on your own. And we can map people against where they are in relation to that life curve and help them with proactive intervention to help delay the onset of statutory requirements in terms of care and other services. So what did we do? Well, over a 6-month period, we invited over 80 users of our services to participate in a proactive telecare pilot where our alarm receiving centre staff had been trained specifically on good conversations, and we linked with the health and social care partnerships and the local authority to help increase awareness of the assets that were available to those individuals to help them to stay fit and healthy and to just really look at what is their best life. And that was really the trusted conversation that the call centre staff actually had. They were working with people for them and to look at them to tell us what would be your best life and what is it that you need and you want to do with us. So it was a completely different way of providing a service. It had huge benefits for the team actually doing this good conversations, and we actually found that the team morale improved hugely. They loved doing this type of work and they found it really, really rewarding. So what we found in our own cohort, the tenants that we had recruited, thinking that they were quite far up the life curve and not really in need of much, we were just talking to them and exploring with them what their best life would be. We actually found that some of them had significant needs, and they actually were under the radar, both of ourselves in the Housing Association, but also within the Health and Social Care Partnership and Statutory Services. And we worked with those individuals, some of whom had to be referred because they had actually a significant need. So it was preventative in the sense that if we hadn't intervened, these individuals would have ended up as a hospital admission. So what was the impact? Well, I've always been a great believer in this Margaret Wheatley quote that when you change the conversation, you change the community. And that was one of the factors that we were deliberately looking at as a housing association and as the chief exec of a housing association. I noticed that it was very different engaging with colleagues in health and social care partnerships and local authority with my housing hat on than it had been 2 years ago when I was Director of Allied Health. And so that intrigued me, and one of the outcomes that we looked at was partnership working. So how do we work truly in partnership with our stakeholders, and how do we affect change across the whole system? And we found this to be a very valuable thing to look at because there was great synergy in what we were trying to achieve. And the tenants who lived in the properties that I look after, these individuals were the GPs, patients, the social care clients, and the health and social care partnership were really interested in knowing about these individuals as well. So we actually did this test of change over a very short space of time. We had 44 beneficiaries, so there wasn't such a high take-up. People they weren't really sure what this was, and actually we undertook over 600 calls during that time. And we did make a difference to a significant number of people as measured by themselves, but also the impact it had in relation to statutory services. So just very quickly, this is one story where it was one of our tenants whose wife had died, and he was feeling really depressed, he was very lonely, and he had become very isolated. And he simply wasn't looking after himself, and he wasn't interacting with medical services, he didn't go to his medical follow-up appointments for his chronic condition. And we actually worked with this individual during this proactive telecare pilot and managed to inspire him to think about what he loved to do, what he wanted to do. And he actually wanted to go sailing with his brother because sailing had been a big important thing in his life when he was younger. So we worked with this man in these proactive telecare calls, and actually he did go sailing with his brother last summer. But he said to us that he really felt that we'd saved his life. He was on a very negative downward spiral, and it was the proactive intervention that made him feel different, take charge of his medical condition, and we referred him on to the medical practice so that he was able to seek the help that he could have. So this is the TSA framework for personalisation and telecare, and one of the things that I would say is we started this project very much on the left-hand side, looking to see how we could enable and empower people and work with the assets to try and prevent them from having a crisis and to try and keep them well and living independently in their own home. And interestingly, what we have learnt from this study, or this test of change, was actually it was really, really hard to make the transition from reactive to proactive as a model. It's difficult for us at the moment to actually prove the benefits realisation and have an outcome measure that can be used strategically and also nationally because the test of change was too small. And also there's the economics. It costs us more to do this, but actually in the long term we think as a system, across the whole system, this is a very cost-effective thing to do for the client group that needs to have additional intervention. So what we're doing now is that we are working alongside Scottish Government. We're involved in Tech Scotland's phase 2 of this pilot, And we've actually shifted to the right-hand side of the proactive telecare framework, and we're going to be running another test of change over the next 4 months, but we're looking more with a different health and social care partnership, but we're looking for people who've had major triggers such as falls and a discharge from hospital, and we're looking to see what the intervention will do for them in the longer term, and to see whether it will actually reduce the escalation of care need and also improve their personal outcomes as a result of the intervention. So very finally, we do this because it's the people that matter. And what I would say is I'm delighted that the focus of this conference is about personal outcomes, because it doesn't matter what we do, we have to remember that these are the people that we're doing it for. Thank you very much.
Thank you. Thank you. So that brings us to the end of this session. Thank you very much for listening. And can I just ask you to do a little round of applause for our speakers? Thank you.